this.
Yes.
You're almost, yeah.
Stabilizing that.
She might have a lumbar extension give, but think about it for me personally. Yeah, I hate this stretch. I can't do it. It's really uncomfortable for me. It's totally fair game. You can absolutely do this stretch. For me, it's uncomfortable, but I teach you all that. You have to make sure you stabilize the pelvis, and then somehow I need to lift her and shift my weight that way. It does not work for my body mechanics. If it doesn't work for your body mechanics, you can find a different way. Don't get locked into a stretch. That's why I'm showing this. If this works for your body mechanics, there's plenty of you who can pick up a leg, maintain good body alignment, stabilize where you're supposed to, and hold here for 2 minutes. Because remember, your static stretch is 2 minutes. You have to hold for 2 minutes sometimes. I cannot hold this for 2 minutes. So I tend to do the supine Thomas test. That's something I can hold. Flip onto your side, facing them. Yeah. You can. So it can become a mechanical stretch if you set them up, but you have to make sure that they're not rounding here. So if you put pillows underneath and prop their leg up on something, as long as they're not giving in their lumbar spine, fair game. Okay? It's not my go-to, but you absolutely can. I just want you guys thinking you don't necessarily have to do a stretch because we taught it to you or because it exists. Find one that works for you. This is one I actually do depending on if it's okay for my patient. So this is side lying. It's difficult for me to stabilize. Most likely she's coming in. I may have to do this. Then maybe I'm internally rotating. So it's a lot more work on me to do this stretch, but I can do it. There are definitely patients who I stretch them on the floor. We don't have a mat available. Thomas test position is not applicable, so I'm here. So I have to find ways of where I can balance and pull her. Sometimes that means I attach a mobilization belt under her leg and attach it around me. Then all I have to do is support her a little bit and pull back.
That's what I was thinking. Like,
Yeah.
if you have The Rock. I mean, it's like, or Dave. And like, yeah, you just like, I'm thinking, yeah,
Yeah.
if you really had to hold it, that would make my arm tired.
Yeah, it would. So think about your stretches. Just because one exists, think about what is better for you, what's better for your patient, and what gets the job done. Just because this stretch can be effective, it doesn't mean it's the one for you at that moment.
Would her stabilizing her bottom leg help?
It can. Try. Hook under. So what it's going to do is it pulled her a little bit here, so I don't have to move her as far. But I mean, Alex is tight. Her leg really doesn't want to drop down. But now I'm getting, I have to stabilize a lot more for rotation. So this is just a lot more work on me. And Alex. So it's a stretch. You can absolutely do it. You can master it. It can look really good. It can stretch the hip flexors. Or you may try it and say, this just isn't working. All right, so you can always try a stretch as long as it's safe and realize that it's not for you, and then you'll learn which ones are appropriate for you. I know the ones that I can and can't do. I'm not lifting anybody's leg. Even if they're on the ground, it's just not, it doesn't work for me. Okay, so there's that one. You have your side lying and you have your prone. Now, if you want to just look at the rect fem, back on your stomach, you guys all know the Eli's test? What am I looking for with Eli's?
Hip.
All right. So if she starts to rotate a little bit here. I can turn it into a stretch. I'm just going to stabilize her. Now, some of my people with very large pelvises, this is not enough, and I literally have to hook under their ASIS and lean onto them, and I'm pulling them this way as I'm stretching them because me pulling them, Alex is small, so if I pull her, she's actually going. But I have patients where I have to pull them in order to accomplish the stretch because no matter what I do, they're just going to rotate away. So sometimes you're leaning on somebody, sometimes you're pulling. You have to find what makes the stretch effective. Don't just go, oh, their ASIS is coming up, whatever. No, not good enough. Find a way, okay? You can see I have her, she could be closer to me, or I can bring myself closer to her. This is still a comfortable position. I'm not arching my back significantly. I'm sort of just in a soft squat position. I could hold this and be comfortable, but
Could you also go to the other side? Would that make it easier?
if I was on this side of her, so I would be like this, and then push down. I could. Sometimes it's not an option, depending on how my.
Time down.
You just strap them down. You can absolutely just go to the other side. You will run into situations, my populations, when they're on a mat, getting them into this position is an ordeal. If I want to stretch both sides, I may not have the ability to go on the other side. So you just learn what you can do in that motion. So I want to teach you guys all little like tricks. Absolutely, you can just be on the same side. This sometimes I actually find easier because I can just sort of sit back a little bit as I'm doing it versus having to lean my weight down. depends on what works for you. That's those two, and let me just see, let me show you hamstrings and then we'll run through that because I want to make sure we get through everything. You guys know how to stretch hamstrings at this point, right? So what do I not want when I'm bringing the leg up?
You don't want your hip to
The
lift.
hip to come up.
Or
The butt
your
to come up.
Right. You're all right. I want to keep the knee straight, and I don't want her hip to round. So I want to go always, always, always to when I first start feeling a little bit of resistance. Alex dances, so she's very flexible. So right about there is her R1. And I give that slight overpressure just like we've always been doing. What is my agonist?
Well, it's a hip flexor stretch. So
Good.
it's going to be your hip flexor.
Good. So if I wanted to do an agonist contract, how do I do it?
Don't let me pull you forward.
Good. Don't let me move you. And then when I say relax, do I do this? No, I keep pushing. Good. Hold, relax. What's my cue?
Don't let me push you.
Good. And what direction am I going in? Good. Relax. Contract, relax. What's my cue?
Push into me.
Good. In this position, if I have a big person, I say, don't kill me, but push down into me. And then she pushes, okay? Because I have had people who have knocked me down to there. You make that mistake once, and you learn to tell people not to kill you.
Classical condition.
Yes.
So lately I've been noticing, and not like you said dancer, but regardless, I've been noticing just because I've obviously been hyper aware lately, a lot of people, not in here, but just in general, like when I go to the gym, a lot of people hyperextend their knees. So in this situation, would it be beneficial to like have them micro bend slightly,
Yeah.
like just like you would if they like elbow hyperextended?
Yeah, very, very valid point. If I'm controlling the stretch, I don't want to do this if she's hyperextending.
That's what I'm wondering.
What I might actually do is come down here so I can keep a little bit of a bend, and now I'm just pushing her from her thigh
Got it.
rather from her leg.
Just because we've been talking it with then, I just think
Yeah.
we put way too much stress.
Yeah.
Like, okay.
Yeah, and there's some research to show that when there's a proximal tightness versus a distal tightness, that you can do different positions. That you're, I don't know, I don't love this that much, but I just want to let you know the proximal is really just that straight leg raise type of thing. Distal, if you're thinking that it's the distal tightness around here, remember the biceps fem does have a second head. You might actually start here and then just bring the knee up as high as it can go. Okay? So you have those two options, that I start straight and go all the way up if I'm thinking it might be a little more proximal, or I can start here, and that's the other way if somebody's hyperextending, that you can avoid it just by taking them there. Okay?
Just feel where it is?
Yeah.
Where it's proximal?
Yeah. Well, I don't know, Dr. Rodriguez, you might know more about this than I do in way of how to sense if it's proximal versus distal weakness. I always went by the short head of the biceps fem. Do you know of a different way they differentiate? Okay, because I think this is a Sarman thing. So, okay, I just wasn't sure.
Passively, right?
It's a sign.
Passively. But I think it's just the short head of the biceps fem. So you might even notice you might notice active, or you might notice that when you put them into stretch that the tibia starts to externally rotate a little bit, which is a sign the short head is a little bit short. So it's trying to, as you bring them up, the tibia might start to externally rotate a little. That's kind of clues you in that it's a more distal tightness. Okay? So,
There were arguments that they thought that you could actually tighten different parts of the
Yeah.
hamstring, even though it's one long hamstring.
yeah,
But I think
that's been refuted, right? Yeah. So
I don't know if they've proven it. I'm
Okay.
one or the other, but.
because I always know it as the short head versus all the like when at the hip, really just the main biceps fem and the two semis are there. But once you get to the knee, now you kind of have like 4 different heads that you're looking at, so that can be the difference. But the literature that I've read is kind of split. That's why I wasn't sure if you had read anything else. I put it in there just so you're aware of it in case you hear of it. I don't know many people in practice that really look so specifically, but just know that biceps fem has that extra head there that can contribute to a movement disorder. All right?
But when we're doing this, like the capstone or any other
Mhm.
reason, you always want the contralateral leg to be straight or can we bend it?
I like it straight. If you're bending it, you're more likely to get a pelvic rounding. But if you bend it because, let's say, they have pain or something, then you just really need to stabilize so that they're not rounding. Okay, so it's fair game to do both as long as you, again, just accomplish what you're trying to do. If I do this immediately she starts to tilt because I've biased her there. So if I had longer arms, it would be easier, or I come down here, I can now stabilize her and move her, but it's a lot more work for me. So it just depends on what your patient needs. If they can keep their leg straight, I would keep their leg straight. It's less work for you to do. Because always something has to be stabilized. So if you can let their body stabilize themselves, go for that. It's just easier. Okay, so
Say that again. Every